Hello, everyone. Welcome to Doc Talks. I'm Dr. Manju George, the Scientific Director at Paletown Development Foundation, the nonprofit that supports Colintown. Today, we are doing a slightly different format. We have Dr. Maddalena here with us, and she's going to go over her ASCO-GI 25 poster. Dr. Maddalena, welcome.
Thank you so much for this kind introduction. I'm back in Italy now. I'm Giulia Maddalena. I spent the last 2 years at MD Anderson with Dr. Kopetz, great mentor, and I'm now back to Italy in clinic in Istituto Oncologico Veneto in Padua. And I'm briefly presenting today cooperation between the two institutions with this project about V600E BRAF-mutated metastatic colorectal cancer subgroup of patients. So my poster presentation at ASCO-GI, it was entitled Challenges in Patient Selection for Surgical Option in V600E BRAF-mutated metastatic colorectal cancer. As we know, metastatic colorectal cancer, there are different subgroups of mutational subgroups of disease, and in particular, V600E BRAF-mutated patients are about 10% of the entire metastatic colorectal cancer patients. And this is associated with poor prognosis, but also it's been studied and it's been noted that this is a very heterogeneous subgroup of patients. So not every history is the same. And we know that a great improvement in the treatment of colorectal cancer is from surgery on metastatic disease. So the integration of surgery along with systemic treatment really improved the outcome for our patients. So while many patients with these mutations have a very aggressive disease and unfortunately, never have the chance to undergo surgery, it is not clear how to navigate the clinical heterogeneity. And if we, as a physician, if we are able to select better patients that may benefit the most from the surgery on metastatic disease. So we collected 71 cases of V600E BRAF-mutated colorectal cancer patients between the two institutions, and we tried to evaluate outcomes according to clinical pathological features such as sex, such as histology, differentiation of the tumor, site of metastasis, such as liver or peritoneum, and sidedness of the primary tumor. In the entire cohort, the median relapse-free survival was about 7.9 months after the surgery, and we were not able to highlight clinical pathological variables that may help in patient selections. The only element that was clearly associated with poorer outcome was R1 resection in the pathological report. It means when in the pathological report, some cells are detected really close to the margin of resection. This is helpful because it adds information in the prognosis evaluation and clinical management. However, it is not something that we can know before surgery. So to the point of the project, how can we better select those patients who may benefit the most? We don't have an answer yet. This was a retrospective collection. Therefore, it is supposed to be hypothesis generating. And basically, the take-home message is that the heterogeneity of this subgroup of patients deserve a better evaluation of every single case. And when surgical resection, it is an option, at least the discussion is worth it to surgery. I really hope this may help some patients to understand their treatment management, and I'm happy to take any question.
Okay, thank you very much, Dr. Maddalena. This was very helpful. So one of the things that I was interested to know is that what kind of treatments did these patients get? Did they get targeted therapy? Is that information known?
So because this is a limited subgroup of patients, this comes from also few years ago when targeted treatment was not available. Therefore, this is a very important point, and thank you for the question. And it is something that we really need to look at, but the information is not available right now.
Okay, thank you very much. So it was very informative that you said that even though your goal was to find out something that would help, learn more about the heterogeneity. Yeah, it is after the results that the main or the only thing that was different was like clean margins versus R1 resection status, right? So perhaps from a patient perspective, looking at it, like somebody with a higher chance of getting to an R0 resection may have a better chance of having longer recurrence-free survival. Would that be okay to interpret it like that?
Yes, I believe it's a good interpretation. To the point is that not always what we see to a CT scan is what a surgeon then detect in the OR. So, of course, the entire evaluation has to be to the point to get a radicality, but we really know that after the surgery.
Okay, yeah, thank you. That's a great point, because you mentioned you're looking at patients with liver disease and peritoneal mets, and sometimes peritoneal mets, like only after the surgeon opens the patient up can they have a better understanding of the extent of disease. So in the end, what you're really saying is that if you are able to get to patients early in their disease with limited metastatic disease, which are surgically resectable to get clean margins, those patients might have better outcomes, right? So it's that, not that surgery. So because among patients, the general opinion is that somebody with a BRAF mutation, they are usually not, when you go to a surgeon, they are usually people are told that you can't have surgery because these have poor outcomes. And, there is also the conversation that because the disease is so aggressive, the physical, issues with, or the time of treatment while the patient is having surgery and recovery, that also has to be factored in. So we usually hear that, these are patients who are told no surgery for you. So this information that you have from this retrospective study is important in showing that there is a subset of patients who may benefit from having surgery, and, learning more about that subset would help greatly, right?
Yes, I agree with you. Unfortunately, for this subgroup of patients, surgery is not always an option, even to the discussion of the surgery, right? But for those patients with a more indolent disease, and this is something that we can see along the treatment plan and how things are going, how the patient is feeling, what's the response to the treatment, even if it's not we still need to, provide data and evaluate this integration with the treatment, especially with targeted treatment. But for those patients with a more indolent disease, a discussion and a limited amount, a limited disease burden, a discussion could be worth it.
Okay. Thank you very much. This was very helpful.